hello to everyone, and thanks for assisting to this important event. For me, it's a big pleasure being here, sharing this time together in order to help to our patients in their journey to create a family. So today we're going to talk about a very important subject. When we have in front of us an infertile couple, we are trying to do something similar to a puzzle. And one of these pieces of the puzzle is the uterine factor. So what we are going to talk about today is the uterine fibroids. And this condition is the most common form of benign tumors. Actually, they are monoclonal tumors of uterine smooth muscles. They occur in the 50 to the 60% of the women, rising to 70% of women by the age of 50 years old. Most of the women with these uterine fibroids are asymptomatic. However, because of the uterine fibroids disrupt the function of the uterus, the 30% of these women have abnormal uterine bleeding, anemia, pelvic pain, dyspareunia, and urinary incontinence. During the pregnancy, these uterine fibroids could cause obstetric complications such as preterm labor, miscarriage, obstruction of labor, and even they could have some pain during the pregnancy. With respect to infertility as a sole factor, it means less than 10% of the fertile couples. It doesn't mean that these uterine fibroids are not common or not important. This is very important condition which we have to study in this infertile couple. Histologically, these fibroids are composed of disordered smooth muscle cells buried in abundant quantities of extracellular matrix. This is very important because this extracellular matrix is a very essential part of the tumor expansion. This activity or this growth of these fibroids depend on the ovarian steroids. It means the ovarian activity, which this means that these fibroids need estrogen and progesterone to grow. The origin of these fibroids starts with the WNT ligand. This particle or this is product that is raised by the mature myometrial or fibroid smooth muscle cell. It may induce in a normal stem cell their renewal. It means the change from fibroid stem cell into the fibroid stem cell to abnormal cells, and probably this cellular origin is because of the mutation of the MED12. So it could cause the change from the normal cell to the abnormal cell. It means a fibroid stem cell, and this it's helped by the WNTB cathepsin pathway, which stimulate the rise of the transforming growth factor B3, and this factor stimulate the growth of the cells around of this tumor cell, so helping to the growth of these fibroids. And it's important to know that these tumors have higher levels of estradiol and progesterone, so it induces a paracrine fashion, making grow this tumor and make it the uterine fibroids. About the risk factors, we can find a lot of risk among these uterine fibroids. So the African American women have a greater chance of being affected by uterine fibroids. The reproductive age is a very important factor because when the menarche is early, the exposition to estrogen and progesterone could lead to the fibroids in the uterus. And the age of the menarche is as well another risk factor because of the reason that I previously told you. And pregnancy could see a protective effect because it appears that the fibroids are more sensible to ischemia, so the volume could reduce during the pregnancy in these patients. But what is the link between fibroids and fertility? Probably one of the theories is the anatomical disrupt of the uterine architecture. It could lead to abnormal contractility and aberrant endometrial growth factor expression, which are going to change the endometrial expression and the endometrial receptivity. Another factor is the altering embryo implantation, specifically in the group of the submucosal fibroids. This is because of the OX10 or the BMP2 and the leukemia inhibitory factor are genes that are expressing during the endometrial receptivity. And in the group with the woman with submucosal fibroids, these factors are reduced. So probably this decrease of these factors are going to alter the endometrial receptivity. And for sure, the hinder stem transport as well is another factor which link the fibroids to infertility. And for sure, the distortion of the vascularization. The effect on infertility depends on the classification of the uterus. And this is the FIGO system classification, which classified the fibroids between from 0 to 7. So the fibroid 0, 1, and 2 correspond to the submucosal group, and the fibroid 3, 4, 5, 6, 7, and 8 are in the group of the intramural and subserosal group. There is another type of fibroid, which is the hybrid leiomyoma. This leiomyoma impacts both endometrium and serosa. So it means that the position of this myoma are in contact with the endometrium and in contact with the serosa. But what is the most important about uterine fibroids? The first location depends on the contact of this leiomyoma with the endometrial cavity or the serosa. These locations are going to talk about the impact in the fertility and for sure the treatment that we are going to offer to this couple. The size, there exists a cutoff in which we're going to interview or to remove this leiomyoma, or we are going to be expected. And the number, it's very important to choose which are going to be the approach of this patient with uterine fibroids. So about location, this systematic review made by Price in 2009 show a decreased clinical pregnancy, ongoing pregnancy, and live birth rate when they compared the group with uterine fibroids versus the control group. It means women without uterine fibroids. As you can see in the red box, there is an important difference when we are comparing the group with fibroids versus the group without fibroids. These fibroids disrupt implantation by 33 to 70% and decrease clinical pregnancy by up to 67%. The evidence is clear about the submucosal fibroids. As you can see, when we are comparing both groups, fibroids with no fibroids, we can see the decrease of the rate in terms of clinical pregnancy, ongoing pregnancy, and a spontaneous abortion rate. And this rate, as you can see, is increased in this subgroup of submucosal fibroids. The subserosal fibroids, the evidence until this moment show a negligible impact on fertility with ART, and it seems that do not appear to have an impact on fertility. Somiglania as well in 2007 in a systematic review which include 11 trials show a decrease in the clinical pregnancy or delivery. So it's clear that the submucosal myomas and the subserosal fibroids, which is the link with infertility. Subserosal fibroids, it's clear they have a negative impact on fertility outcomes, and the subserosal fibroids doesn't have any impact in the reproductive outcomes. But what happened with intramural uterine fibroids? Probably this is the gray zone that we have when we are talking about intramural uterine. And to answer these questions, there is some studies such as this by Sankara in 2010 with this systematic review and meta-analysis, which studied the impact of the non-cavity distorting fibroids with infertility results. And in this study, they studied the non-cavity distorting intramural fibroids respect to the impact and infertility, and showed that in fact they reduce the labor rate 21% and the clinical pregnancy rate 50% per IVF cycle. It means that even when they are not distorting the cavity and they are just touching the cavity, they reduce the rate of the live birth rate and the clinical pregnancy. But about implantation and miscarriage rate, there is no statistical difference. Another study published 8 years after of this study by the Dr. Wang. This include 28 studies in this meta-analysis, and as the previous study, it doesn't show an increase in the live birth rate. Actually, the live birth rate decreased in this group of leiomyomas, and as well, the implantation rate was less than the group without fibroids. And the pregnancy rate is not surprising. It's reduced when we are comparing this group with this kind of fibroids with the group without fibroids. But if we see all this scientific evidence, we can think that these intramural fibroids need treatment to all the patients that are going to our consultory looking for help to get their pregnancy. But this intramural fibroids, it's a very heterogeneity group, and these studies do not stratify by fibroid size or location, proximity of fibroids to the endometrium, age of patient at time of diagnosis, or the method the fibroid was detected. So what would be the factor or the point to guide us if we have to treat or not treat this specific intramural fibroid? Some evidence could put the size as an option to determine if we have to remove this intramural fibroid or if we don't have to remove it. About removed this intramural fibroid, this study is a prospective study which includes patients from 25 to 39 years old. Normal factor for sterility, bilateral double occlusion, or diagnosis supporting abortion risk other than the presence of myomas. In this study, there include 1 to 5 myomas greater than 5 centimeters without submucosal myomas, and these women were undertaken to laparoscopic myomectomy. And what they find? They found that there is a statistical difference between the group that were undertaken to the remove of these kind of intramural fibroids when we compare the women that they were not taken to remove of these fibroids. Another study compare women with asymptomatic intramural of subserosal fibroids with a diameter below than 50 millimeters or 5 centimeters. And they compare this group with women free of fibroids in IVF cycles. This group were composed by 119 cases versus 119 controls. So the people in these both groups are the same, and they were matched by age and number of cycles. And why they didn't found any difference between the women that were undertaken to remove of these intramural fibroids below than 5 centimeters, and the implantation rate doesn't change. So it means that there is no benefit to remove intramural fibroids below than 5 centimeters. So it looks, as we saw in the last study, that just the fibroids that we remove and then offer some benefits are those fibroids more than 5 centimeters. So the symptomatic patients selected for IVF small fibroids with a diameter more than 50 millimeters or 5 centimeters and not encroaching the endometrial cavity, surgery did not impact on the rate of success of the procedure. So the question is, all the intramural fibroids have the same impact? Is no, because the intramural, as I said before, is a very heterogeneous group. We could find an intramural fibroid in contact to the endometrial cavity, and as well we could find intramural leiomyoma close to the serosa or between the myometrium. But these three positions has a completely effect on the fertility outcomes. So to answer this question and to make a difference between these intramural fibroids, we must talk about the uterine fibroids FIGO3. And these fibroids, as we remember in the FIGO classification, are the intramural fibroids that are in endometrium and in myometrium, but they are in contact to the endometrial cavity. So this study published the last year, which have patients from 20 to 40 years with single or multiple fibroids, non-distorting uterine cavity, but abutting endometrium. And these were diagnosed by ultrasound, and they were undertaken to hysteroscopy to rule out cavity involvement. And this patient, after this procedure, after diagnosis these fibroids, they were undertaken to first embryo transfer. But these patients were compared with no uterine factor and no endometriosis. And in total, they were in the study 70 patients. And this group was compared with the control group. And this group for sure had a normal uterus, and it was confirmed by 194 patients. So what they found when they compare the fibroids FIGO3 with no fibroids FIGO3, they saw that the implantation rate and the pregnancy and the clinical pregnancy rate was decrease when we compare this group of fibroids with the control group, with that statistical difference, which means that the fibroid FIGO3, they could cause infertility in the women who have this kind of fibroids. And as well, the labor rate is decreased in this group with FIGO3 compared with women without this kind of fibroids. And if we do analysis by subgroups, we could see that if the patient has just one fibroid, there is no difference when we compare this patient with this leiomyoma with a patient without this leiomyoma. But if this patient have more than 2 fibroids, the change or the difference we could see with this statistical difference, which is closed by these red box. But if we saw about the diameter, a fibroid with more than 3 centimeters or more than 30 millimeters could change the results, talking about live birth rate, implantation rate, and clinical pregnancy rates. So what is saying to fibroid doesn't impact on the fertility outcomes, but if we have 2 or more fibroids, it does have an impact on infertility outcomes. And if we have a fibroid figure 3, and this is greater than 3 centimeters, obviously this is going to reduce the probability to have a live birth rate, to have a good implantation rate, and for sure to have a clinical pregnancy rate. So if we are talking about the management of these uterine fibroids, we have 2 options of 2 arms. And which is the best? Well, it depends on the time that we have with this patient. But to be honest, in assisted reproduction, we take the surgical option because we want to resolve this problem to the patient, trying to make shorter the time to get the pregnancy. So this surgical approach, we could find 2 options. The first is the vaginal approach, and the second is the abdominal approach. So in the vaginal approach, we find the hysteroscopic myomectomy, and this procedure is indicated in women with fibroids with classification figure 0, 1, 2, or 3. And remember that the figure 3 must to have a cut of more than 3 centimeters to remove it by hysteroscopy. Actually, Mason, in his study, he reported 87% of the complete remove of this fibroid in the first step. However, the 12.3% needed multiple steps, and it depends on the size of this fibroid. Actually, fibroid more than 3 centimeters need more than 1 step to remove this fibroid totally. And the pregnancy rate post-surgery is high, actually is 45%. After this procedure, actually, this couples and this study got the pregnancy in a spontaneous way. And the other approach is the abdominal laparoscopic myomectomy or the laparotomy. They, in these studies, reported a pregnancy rate about 50% after remove of these fibroids, but more than 5 centimeters. We must remember that the fibroids below 5 centimeters doesn't have any impact on fertility outcomes, but those fibroids with more than 5 centimeters does impact in the obstetrics or reproductive outcome. So we must to offer to this patient the remotion of these fibroids. If we choose the open or the laparoscopic approach, it depends on the diameter of these fibroids, and if we have 1, 2, or more than 2. If we have a fibroid more than 10 to 12 centimeters or multiple myomiomas more than 4, we have to offer to our patient the laparotomy way. But if we have less than these leiomyomas or this fibroid size is less than 10 centimeters, we could offer the laparoscopic myomectomy. There is no difference in live birth rate between these both approaches, and this is according to the results published in Cochrane 2020, and the recurrence risk is similar between these both approaches. So what about the time to get pregnant after the myomectomy? This is a very common question because the evidence until now has different results about the time. And this paper was published on this year try to show with this the mean that the gynecology offered to the patient or advised to the patient to wait until looking for the pregnancy. So the mean in this study, which include 80 studies, it's 70.6 months. But if we see all the results after the myomectomy, even if it was by laparoscopic approach or if it was by open approach, after this procedure, these couples could reach 70 spontaneous pregnancies. And the mean time between myomectomy and conception was 26.1 months. And the shortest interval was 3 months, with the mean 4.3 months. So most uterine ruptures, there was no relationship between time from myomectomy to conception. So there is no relationship between the time that we take after the procedure and the moment that we start looking for the pregnancy. And it's clear that radiological findings show that the uterine healing can be achieved after 3 months. However, it may not be achieved until 6 months. So with this result, we could advise to our patient to wait at least 3 months to start looking for a pregnancy. It could be in a normal way, in a spontaneous way, or with assisted reproductive technology. And this time also depends on the size, location, energy that we use during this procedure, and the complications post-surgery. And with respect to medical treatment, we have the hormonal therapy. And among these options, we have 2 medications, the ulipristal acetate and the GnRH agonist. So this figure shows the mechanism of action of these 2 medications. The GnRH agonist is indicated to preoperative administration to reduce the volume of this fibroid. It could decrease the preoperative anemia, and it could give us the chance to schedule the surgical procedure. About progesterone receptor, as we saw in the first slides, we see that to the growth of these fibroids, they need progesterone and estrogen. Even when the estrogen is important in this physiopathology, the progesterone is the most important role in these fibroids. So this selective progesterone receptor modulator play a key role in the uterine fibroid growth. According to the Pearl studies, it's a good option for long-term management with heavy bleeding, and it could reduce pain and fibroid volume. But due to some side effects that this medication had in the past, the EMA, which is the entity that control the medication in Europe, they said that women who are not candidates for surgical fibroid resection are candidates as well to this therapy. But this therapy needs time, and sometimes in assisted reproduction we don't have that time. As we can see in this image, after course number 4, we could reach even the 67% of the reduce of the volume of these fibroids. So it could be a good option, but this treatment is a bad option for those women who have time. But probably in assisted reproduction, we don't have this for courses, but if we count all this time, it would be more than 1 year. So it could be a lot for a woman who are looking for a pregnancy. And there is for sure another alternative, and we could find these 3 options. The first one is the magnetic resonance guide focused ultrasound surgery. The second, the uterine artery embolization, and the third one is vaginal occlusion of uterine arteries. These are a good alternative in patients who are not candidates to the surgical treatment. But what happened with this alternative? They have a negative impact in ovarian reserve. So this is a thing that we don't want in our patients. So in this context, this is not could be an option for us. So as conclusions, the leiomyomatosis is a challenge, and it's a challenge because until now, we have leaked evidence about intramural fibroid, which is the gray zone that we have, but I try to clear this. It's important to good ultrasound mapping of the fibroids, determining the location and size in order to give the best option of treatment to our patient. It's clear that intracavitary fibroids and intramural greater than 4 centimeters must be removed. So we must treat this kind of fibroids, intracavitary fibroids and intramural greater than 4 centimeters, as we saw the results in the studies. And the subserosal fibroids definitely don't have any effect on fertility, so they don't need treatment no matter the size of these fibroids. And treatment must be individualized according to the symptoms and whether or not there is infertility. And us as clinicians should wait 3 months after surgery prior to IVF. By this time must be considered in older women with low ovarian reserve. If we have an older woman with ovarian reserve or a woman older than 35 years old, and these women have a uterine fibroid and these needs surgery, we must to offer embryo cryopreservation before the treatment of this leiomyoma. Why? Because we must to wait at least 3 months. And if we are waiting these 3 months, probably the results are going to be negative at the end of this period. And if we treat or we do embryo cryopreservation before this treatment, we could have a good result. So thanks one more for assisting to this event. It's a pleasure to me sharing this time together. So I'll be waiting for your questions. Thank you.